Hi, good afternoon, everybody. Hello. Hi, my name is Yvonne Rogers. For those of you who don't know me, I am the Vice President and Program Director for the Women with a Vision chapter of Women of AT&T. And of course, we have to introduce our other board members who are here tonight. Karen Gerhold is our president. She was doing registration. Linda Kornacki-Coons, our membership director. And Juanetta Phillips is here with us tonight. She's our parliamentarian. And I believe, is that it? Ingrid's not here? Samia Franklin is here, our secretary. Okay, all right. Well, we'll just go ahead and get started. A couple of board members are not here tonight, but first of all, I want to extend a warm welcome to any new members. Do we have any new members registered tonight? No? Good. Okay, so these are veterans. That makes it even better. Oh, we have one? Who? Grace? Grace is a veteran. Are you kidding? Grace Ehrenbeck, she started this organization. So welcome, everybody. Hopefully you guys all had a chance to partake in some of the festivities or activities we had today celebrating National Women of AT&T. The National Women of AT&T Day actually is recognized this year, and we celebrated 40 years this year. So congratulations. Okay, so before we get started, of course, we have to give a few housekeeping items. Please be courteous to our speaker and to those around you by keeping your sidebar conversations at a minimum. Please also wait for a microphone so that any questions you ask can be heard. If we don't get to a microphone in time, if Dr. Altman, if you could just repeat the question, that'll be helpful to make sure, because we're videotaping, so we want to make sure we get everything on the videotape. And also, before you leave the auditorium, please make sure you take all of your belongings with you, especially if you want any of the auction items, you lucky people, Sandy Seidorf. So now I'll introduce our speaker tonight, Dr. Emily Altman, and she's going to help me with one of these words. Dr. Altman is a board-certified dermatologist and pathologist. There we go, it's a big one, who specializes in medical, surgical, and cosmetic dermatology in Livingston, New Jersey. She's a graduate of New Jersey Medical School, and she completed her residency in dermatology at Columbia University in 1997. You guys had the opportunity to print her bio from the website, so hopefully you did that. You can read all about her licenses and her other honors. With that, I won't go into detail. With that, let's give a warm welcome to Dr. Emily Altman.
Thank you. I didn't realize I was going to be here on such a special occasion. Congratulations to you all on your anniversary. Okay, so I was invited to talk about sun damage and skin cancer. And before I get to that, I wanted to just talk briefly about why I went into dermatology in the first place. Dermatology is an amazing specialty. It's one of those specialties that unites everything together. We have surgery, we have pediatrics, obstetrics, the entire thing, immunology, genetics, all of these specialties are tied into dermatology. And the skin has representation of all the organs and all the diseases. So we can diagnose from the skin where a person has been, how long a person smoked, whether they have diabetes, a whole bunch of things you can see on the skin like an open book. And frankly, that was the first thing that attracted me to dermatology, because it's really a detective story every time. All right. So I wanted to start the talk by going over the skin structure, because that will relate to what we're going to be talking about later. So this is a cartoon of the skin, and there are three layers. The epidermis, which the top of the epidermis is the dead skin, which sheds off all the time and constitutes about 90% of the dust in your house. Below the epidermis is the dermis, which is made up of connective tissue that gives the skin strength and elasticity. So it's made up of collagen and elastin, and also molecules that hold water, which is hyaluronic acid. So that gives the skin plumpness and resiliency. And then below these is the fatty tissue. So through the dermis and up into the epidermis run the appendages, hair follicles, sweat glands, all of that. Okay, so before we get to sun damage and skin cancer, I wanted to talk about some common conditions that pretty much everybody experiences. So acne, about 40 to 50 million people each year in the United States alone. So everybody gets a pimple or two occasionally. And then this 40 to 50 million are the people who have clinically significant disease. It affects both men and women. It affects primarily teenagers, but it can affect anybody at any age, from newborns way into elderly. Okay, and what happens with acne is it's affected by hormones, so it's primarily active during hormonal changes, teenage years, perimenopausal time, etc. So, and of course, when people are taking medications like prednisone, which is also a hormone, that also brings out acne. So this is what common acne looks like: little pustules, papules, blackheads, whiteheads. This is clearly a teenager. Okay, the next very common condition is eczema. Eczema is itchy, scaly, dry skin, basically. There are people who are predisposed to eczema based on their genetics, that it runs in families. These families also have hay fever, asthma, sensitivity to aspirin, to penicillin, and altogether this syndrome is called atopy. But everybody gets a little eczema. When it gets cold enough outside or when you overwash your hands too much, you're going to get red, scaly, and itchy. So this is what eczema looks like, okay? This is typical. Oh, this pointer is misbehaving a little bit. So this is typical of what you get in the winter, this red, kind of poorly defined, scaly, very itchy rash. And of course, the fingertips can split and they hurt like heck. This is a close-up of what happens on the legs when the skin dries out. And the reason why this condition is called eczema craquelé is because you can see these fissures or cracks all the way through. So another very common condition, freckles. Primarily, we see them in little kids, and primarily in kids that are very fair, that have light-colored skin, they have probably red hair, red eyebrows and eyelashes, and they have lots of freckles. Well, freckles are not only seen in fair children. Freckles are also seen in sun damage. So for example, these young ladies, they also have these freckles, right? But if you look at where these freckles are located, they're located on areas where they had sunburn after sunburn after sunburn. Because right here, there are no freckles. And also in the areas that are protected from the sun, like under the eyebrows, there are many fewer freckles than everywhere else. So this is already sun damage. And this is the extreme of sun-damaged freckles. Now these freckles acquire a little bit of substance. These are seborrheic keratoses. You can look at the skin. It's no longer individual little freckles. The whole skin is mottled and wrinkled and thinned out and has these crusty keratotic areas. So that's sun-damaged freckles. Okay, so let's talk a little bit about aging. There are two types of skin aging. There is intrinsic aging, which happens to everyone, everywhere, including covered up areas. That depends on how your skin repairs itself and on your genetics. There are people who are genetically predisposed just not to age, and at age 90, they look absolutely fantastic. So where we see intrinsic aging is all over. Okay, but if you want to really detect what intrinsically aged skin looks like, you go to the covered areas, especially the doubly covered areas, like the lower abdomen. You can see there what the skin would look like if there would not be sun damage. So extrinsic skin aging, that is primarily photo damage. About 80% of skin aging, or what we recognize as skin aging, looseness of the skin, laxity, sort of yellowing, pigmentation changes, all that. That is caused by ultraviolet light. That is photo damage. And there are contributions from other things like air pollution and smoking. But this is the most important message that I could actually give to anybody that I speak to, including all of my patients. The most important anti-aging procedure that I can offer is sun avoidance and sun protection in the first place. So if you don't get the damage, it's really quite fantastic. You don't have to do all the repair work afterwards. So what does ultraviolet light actually do? Ultraviolet light does a couple of different things. It, first of all, affects cells called fibroblasts. Fibroblasts make collagen and elastin in the skin. So these fibroblasts stop making it, or at least slow down quite a great deal. It also affects the collagen fibers themselves and breaks them down. So instead of giving resilience and strength to the skin is quite loose. The elastic fibers, which are the ones that give you sort of the snap back when you pull the skin, those, when you look at sun-damaged skin, they're basically clumps of grayish material under the epidermis, under the very top layer, instead of being distributed all throughout the skin and giving the skin, bounce. So if you, okay, let's go. Okay, so let's talk a little bit more in depth about ultraviolet light. So ultraviolet light is divided into 3 segments. The short wave, which is UVC, which is thought not to reach the Earth's surface because of the ozone layer. And with all the talk about the ozone layer, there may be some of this getting through, but we're not detecting it quite yet. But if we do damage to the ozone layer enough, we're going to get it. This burns, and burns very quickly. We use UVC in laboratories now to sterilize things and to treat different experiments, but we can't really detect it on the Earth's surface right now. What we can detect quite readily is UVB. This is the medium wave. This is the wavelength that burns. Yes, you tan with it, but that's primarily what burns. And it does a lot of the damage to the epidermis, to the keratinocytes, which is where the skin cancer comes from. Long wave, UVA, reaches way deep down into the dermis, sometimes down to the subcutaneous fat. It doesn't burn, but it does all the sun damage and all the predisposition to skin cancer that UVB does. We just don't get out of the sun if we get UVA. And if we see, as we see later, we get plenty of UVA through car windows. And they don't block UVA. They block UVB, but they don't block UVA. So what happens when UV light hits this is DNA molecules in the keratinocytes in the surface of the skin. What happens when UV light comes in? UV light comes in, breaks the strands, and forms abnormal dimers called pyrimidine dimers. So when this cell goes to replicate, half of these cells is going to be normal, and half of these cells is going to inherit this abnormality. And this abnormality is the first step to the formation of skin cancer. So this is one of the posters from the American Academy of Dermatology, clearly designed to get someone's attention about sun damage. This is a 19-year-old young woman. This is what she looks like, and this is what she looks like by UV photography. All this is sun damage, and she's 19 years old. Okay, so how do we classify sun damage? Dr. Richard Glogau designed this nifty scale. There are lots of different scales on how to evaluate sun damage, but this is actually quite useful. So sun damage begins to be visible somewhere around age 28, 30, and it progresses depending on how much sun a person gets. So in the very beginning, group 1 is mild sun damage. That's early photoaging. There are very minimal pigment changes. There are no keratoses, these crusted lesions that we looked at before, minimal wrinkling, and makeup is not really necessary. In the moderate group, 35 to 50, we have wrinkles in motion. So when a person expresses any kind of emotion on their face, you see that folds are beginning to form. But these folds smooth out when the face is at rest. And so we have early brown spots. We have some keratoses that you can feel, but you can't quite see yet. You see that smile lines begin to develop, and some makeup is necessary to hide some of these defects, shall we say. Now, I'll grant you, this was designed by a guy, so he is the one telling you how and when a woman should wear makeup. So take it with a grain of salt, okay? I'm almost 51, I don't wear makeup. I have a little bit of sun damage that I would like to not have had, but I'm not a big fan of makeup, so I don't wear it regardless of what Dr. Guagao says I should do. So the next one, let's go back. The next one is advanced sun damage. So this is 50 to 65. Now wrinkles at rest, okay? So even when the face is relaxed, wrinkles are present there. So obvious discolorations, dilated blood vessels, visible keratoses. And then the severe, 60 to 75, only wrinkles, okay? Because there are no smooth areas on the skin. So just as a comparison, this is group 1 and this is group 4. And you can see that there are no smooth areas on this skin. This lady has light colored eyes. Her eyebrows are kind of a light brownish, and you can tell that her skin is really susceptible to sun damage. So she acquired all of this damage probably quite early on. Okay. So this is a really good question about car windows and office windows, by the way. So they block UVB, but they don't block UVA. And as we talked about, UVA does as much damage and is as carcinogenic as UVB is. It just doesn't burn. This is a photograph taken from the New England Journal of Medicine just very recently, maybe 3 or 4 weeks ago. This gentleman is a truck driver, and this is the side that's constantly facing the window. Okay, that's pretty dramatic stuff, I would say. So this gentleman is an office worker who sits with this side towards the window. Okay. So this comes from a textbook of dermatology by Dr. Bologna and others. It's really quite impressive, okay? This is chronic. He doesn't get burned, so he doesn't really pay attention. It's nice and warm, the sun is coming in, it makes you feel better, but the damage accumulates. Okay. So I mentioned a little earlier that people that have fair skin are the most susceptible to skin cancers. Before we go on to discuss skin types and susceptibility to skin cancer, I have to say that anyone can get skin cancer. It doesn't matter whether you burn in an instant or whether it takes you forever to burn or you don't burn at all. Anyone. Okay, so it's not protection that you can go out and tan very nicely and not burn. You really have to protect your skin. So type 1. Type 1 has the least amount of pigment called melanin in the skin. Melanin, which gives us the brown color in the skin, because we have other pigments like carotenoids that give us yellow and hemoglobin that gives us both red and blue, depending whether it's arterial or venous blood. But melanin is the main pigment in the skin. And what melanin does is it absorbs ultraviolet light. So the more melanin you have, the less ultraviolet light gets through to the deeper layers where it can do the damage, where it can harm these cells and make these cells precancerous and then push them on to become skin cancers. So type 1 are the ones that have very little, if any, melanin. And so they are the ones that are most susceptible. They're pale, fair, they have freckles, they always burn and they never tan. So they go out in the sun, they turn red, they peel, and they're the same shade as they were before. Type 2 tans sometimes, but usually burns, and they have very fair skin. Type 3 may burn, usually tans, has kind of light brown skin, and etc. To type 6, which has marked constitutional pigmentation, so the skin is dark brown. Skin types do not correlate to ethnicities. Any ethnicity can have multiple skin types in it. So, if somebody says, oh, she's from Puerto Rico, it doesn't make any difference to me, okay? Because there are type 1 people who are Puerto Rican and type 6 people who are Puerto Rican, and so skin types are definitive. They are a scientific way of looking at the skin. Ethnicities are not. Okay, so what happens if you have chronic sun exposure and you don't wear sunscreen? The skin has a couple of mechanisms it can protect itself. It can increase the melanin content, right? Because melanin absorbs ultraviolet light. So if the skin is going to be chronically sun exposed, it's just going to get darker to try and protect itself. If there's not enough melanin, what the skin does is it thickens, because the keratin layer, the dead skin cell layer at the very top of the skin, scatters the ultraviolet light. So also less gets through. But these are not perfect mechanisms, and ultraviolet light gets through and does its damage. Okay, so some statistics. 1 in 5 Americans will develop skin cancer during their lifetime. The most common skin cancers include actinic keratoses, which are some people consider a precancerous skin condition, and some people consider skin cancer already. It's precancerous to squamous cell carcinoma. And the thought is that these guys, it's only a matter of time until they go here, okay? Basal cell carcinoma, squamous cell carcinoma, and the big bad one, malignant melanoma. Okay, so back to our skin structure. This is the dead skin cell layer, this is the epidermis, and this is the dermis. The basal cell, the very lowest layer of the epidermis, is where a basal cell carcinoma comes from. The spinous layer, which is the area of epidermis between basal layer and the dead skin layer, that's where squamous cell carcinoma comes from. And then these innocent-looking clear cells in the epidermis here, these are melanocytes. Melanocytes make melanin and distribute it to the skin cells. So they are not the only ones with melanin. What they have is they have these little projections that attach one melanocytes to about 10 keratinocytes, and melanocytes continuously make melanin and distribute it to the keratinocytes. This is the source of malignant melanoma. Okay, so this is basal cell carcinoma. It's the most common cancer in the United States, probably the most common cancer worldwide. It affects approximately 2 million people each year. The statistics are rising tremendously. So this is last year's statistics. It may be significantly different now. So it's the most common cancer in the world, period. And so when you look at this, it's a red spot, right? It's a little bit of crusting, that's true. It's made out of a relatively friable material, so if you rub it or scratch it, it bleeds pretty easily. And if you look at the edges of it, it's kind of got a pearly edge. Okay, but this is also a basal cell carcinoma, and for all the world, it can be mistaken for a patch of eczema. Except this patch of eczema doesn't itch, and it continues increasing, and moisturizers don't help it. Okay, this is actinic keratosis. As I said, it's a precancerous lesion. It's considered that it's only time before it gets to squamous cell carcinoma. And if you look at the pictures, and I'll show squamous cell carcinoma later, you'll see why they just go from one to another. Up to 60% of all people 40 years old and older in the northern hemisphere will develop actinic keratoses, and they are just little red crusted spots. In the beginning, you can't even see them. You can just feel them because your finger just catches on something that feels like a little bit of sandpaper on your face. So this is when we do a full skin examination, touch is a very important thing because sometimes you just can't see these. This is squamous cell carcinoma. This is the second most common skin cancer in the United States, more than 700,000 cases. This one is a little bit more dangerous than basal cell carcinoma. Basal cell carcinoma is primarily locally destructive. It'll grow and it'll form a little ulcer and it may be a mess to clean up, but it really doesn't travel anywhere. Metastatic basal cell carcinoma is really reportable in the medical literature, so it's all local. But these guys, if left long enough or let to grow large enough, they will metastasize, especially if they are on the ears, on the scalp, and on the lips. Those are the big sites. This one, more than basal cell carcinoma, depends very much on the function of the immune system. So the immune system really tries to hold this thing from spreading. And we know this because people who are solid organ transplant recipients, whose immune systems are completely snowed in order to keep their organs intact, they are about 250 times more likely to get squamous cell carcinoma than people whose immune systems are intact, which is pretty amazing and not in a good way. All right, so this is the bad guy. So melanoma is the most serious and potentially deadly form of skin cancer. We talked about the fact that it grows from cells called melanocytes, the ones that make the pigment. Now, incidence of melanoma. The statistics are absolutely striking. In the 1930s, 1 in 500 people got melanoma. Now it's 1 in 59. So it's scary. It's scary. And the thing with melanoma is that if you catch it early, very early, before it spreads, the cure is practically 100%. Once it goes, we have all these medications now, biologics, chemotherapies, none of them help. We can help maybe 10% of the people that have melanoma, that have metastatic melanoma. So the whole idea is prevention and early detection. Okay, so this is also striking. The sixth most common cancer in the United States and the leading cause of cancer deaths in women between the ages of 20 and 35. Every hour, one person dies from melanoma in the United States. These are very scary statistics. Okay, so how do we recognize melanoma? This is a nifty little mnemonic. These on this side are normal moles, and these are melanomas. So A, B, C, D, E, asymmetry. If you look at this guy, if you cut it this way or this way, one half looks exactly like the other. But in this one, there is no way to divide it in two where one half will look exactly like the other. Border irregularity, nice smooth border, and here all these little pseudopods and outpouchings, the border is not smooth. Color irregularity, one color here, either multiple colors or multiple shades of the same color. And the diameter is less important now. It used to be thought that anything that's larger than the eraser of a pencil, that's kind of the key, you know, that's the one that you have to worry about. We see very tiny melanomas. This is the most important thing. If it's changing, if it's growing, if it's lifting, if it's symptomatic, itchy or painful or bleeding or doing something odd, that mole has to be seen by somebody who can evaluate it. All right, so I preempted myself with this slide. All right, so this is brochure actually from the American Academy of Dermatology showing how to do a self-skin examination, just like women do a